So, welcome everyone. I'm really excited to welcome you to another episode of our Sunflower podcast, which is a podcast exploring all aspects of children's palliative care around the world. So, the Sunflower podcast is really hoping to bring curiosity, humor, and reflection to the world of palliative care. We're going to explore the joys and challenges of working in this incredible field, including topics related to education, advocacy, self-care, service provision, and leadership of palliative care teams all across the world. Whether you're a nurse, a counselor, a pharmacist, a doctor, any type of healthcare professional, or just someone who is interested in learning more about pediatric palliative care, then this is a podcast for you. I'm one of your hosts, Natasha Datoo, and today I have the privilege of being joined by Camara Van Breemen, who is a pediatric palliative care nurse practitioner, and she has worked at Canuck Place Children's Hospice since it first opened and has been a specialist in pediatric palliative care for decades, as she says. So welcome, Camara. I don't know if you want to say anything else about yourself.
Hi, Natasha. Yeah, it's great to be here today and just have an opportunity to have a conversation. I think the other thing I would add, and you already know this, we work together volunteering with Two Worlds Cancer Collaboration and have had an opportunity to work together with our partners in South Asia to really enhance and grow and learn from each other how to deliver pediatric palliative care. So yeah, just really, really happy to be here today.
We are very happy and privileged to have Camara joining us. So, one of the questions I continue to have and always, find is interesting, and I'm hoping Camara, through all of her years, has seen some good and some bad on how do we introduce the idea of pediatric palliative care to a team, to a family? How do we take away some of that fear?
I think that's a great question. And I know you and I have talked about it a lot. And I know every time we have a new learner, they're like, well, do I just go into the room and how do I kind of explain our program? Or we hear from other clinical teams like they're not ready for you yet, or they're not ready for palliative care yet. And so, I think to start off first is language really matters. I think this idea that the words we share, how we introduce ourselves, why we're going into the room, why we're talking to families, I think kind of that's where we have to start,
Mm-hmm.
I mean, you're an oncologist, right? We see how some oncologists can really introduce us in a way that's like, oh, that was gentle. That made sense. That's a partnership. And then sometimes there's oncologists that don't really know how to talk about pediatric palliative care, or in our case, Canuck Place Children's Hospice.
Yeah, I think that's a really good point. And I think one of the things I always think about is if us clinicians who are in this role are scared of palliative care, which I have colleagues who aren't comfortable with the idea of palliative care, then of course the way you introduce it is going to feel not genuine, or the family is going to pick up on how nervous you are to introduce that team. So I think the more we can expose the healthcare system to, whether it's Canuck Place or the palliative approach to care or what we really do, will then allow people, they have to have the experience, right? I think once a clinician or a nurse or whoever really sees how we can help families and children, they never forget it. And then they want to have that support for all their other families. So I think the experience is helpful for all of our team members.
Yeah, so I think you make a good point, like starting with the clinician, right? So starting with the clinicians who are working with seriously ill children and saying, let's consult about this child's pain or about their worry that they have for this child, that their cancer is getting worse or their lung disease is getting worse. And sort of spending that time with the clinician to say, what do you think we can be helpful with, and what are some of the things that you think our team might come alongside and support. So I think that's part of it. At the same time, I think there's times that we get a sort of a soft referral, meaning the specialist wants us to be involved, and we sort of have to have the guts to go into the room and say, hi, I'm from the pediatric palliative care team or the Canuck Place team, or your specialist asked me to come and see you. And that takes some courage, I think,
Yeah, it's interesting. And when I was just in my oncology role for the last 3 weeks, and it reminded me that you have to be really brave as the clinician consulting too. You have to be brave, and you have to trust that it's a team that will be able to support you and the family that you're thinking about in many different ways. And that doesn't just mean end of life care. And I think it is hard because it sometimes, even as a clinician, it feels like you're giving up. But when you really know what a palliative care team does and what the meaning is, improving quality of life, helping with symptoms, really helping kids and families live as best as they can for as long as they can, you have to see it. So I think exposure is huge. And I think I think that's why I think both of us are so invested in teaching trainees about what we actually do, and translates to how we're introduced, I think.
I think one of, you'll know who I'm talking about, one of our favorite people, oncologist, the way he introduces our team is, well, first of all, he has trust with the family because he's been treating their child with brain cancer or with, another type of cancer. And I've been in those meetings where he says, can you come? Can your team come? Camara, can you come? Or Natasha, can you come? Or whoever is on consults that week. And we'll say, I'm bringing in this person or this team because I really need their help to help me take care of you better. Mm-hmm. And when the family hears the specialist say, I trust this team, I need this team to help care for you better, the family automatically says, well, of course I want to meet these people. Of course, if my oncologist or my respirologist or my whoever says that you should meet this team, then the family is going to be more open. And the other thing I like about how he introduces that is he doesn't say what we're going to do exactly. Mm-hmm. He says, this is a team that has specialized skills and I want them to come alongside. And he invites us into that room to be able to share what we might be doing. And that kind of leads me to another point around, before we meet a family, we have to think about what's the child's diagnosis, what's going on with their illness, how sick are they, what's their family like, what are they struggling with? Because I might go into a room and say, what do you understand about how we can help? Or I might already know that their child's in a lot of pain that has been difficult to manage. So I might say, I'm here to talk to you a little bit about your symptoms today to see if we can help sort those out. But if the child's actually quite well and doesn't have a lot of symptoms, I might be thinking, I know you have a brother and sister and the family's really struggling because they've had to be in treatment and away from home. And so it's one of our offerings, family support. So trying to feel the match of what our team can do with what the family needs. I think that's another way to think about, how do I introduce us? I have to introduce us in a way that aligns with what's needed and what the family might be looking.
Yeah, and it's a good point in terms of, I think that's one of the magical things about palliative care is we really can meet families where they're at, right? So we're the flexible team. We can mold and change things around for whatever family needs in that moment. And I think it's totally fine wherever you work in the world if you don't know what your palliative care team does or offers, but that they might be able to help. So one of the things I encourage my colleagues to do is call us first. Call us and say, I think you might be able to help me with this family. What do you think? Like, how should I bring you up, right? And then we can offer some suggestions to the team and the people that this family trusts, as Camara said, because they don't trust us. We're new to them.
Yeah.
So I think that's one of the things I would say is, if you're never sure, please call your trusty palliative care team and let's talk about what way that you can bring us in. And then we can do a needs assessment and help support families in those moments. But it's never wrong to think about offering palliative care. If you think about it, call us, is what I always say. And maybe it fits and maybe it doesn't, but never a bad thing to ask is what I tell a lot of the trainees, actually.
I think you and I have both heard, we'll hear from our colleagues that this child's very sick. They might be in ICU, or their cancer's relapsed for the second time, or something's going on that's really demonstrating that the child's not well. And we hear from some of our colleagues that don't know how to introduce us will say, the family's not ready for you yet. And I always find this an interesting dialogue to have with people because, I'll say things like, well, are they ready for added layer of support? Are they ready for a team that not only supports families in adapting to illness, but adapting to grieving and thinking about what location of care they want to be in? Is this family ready for things like recreation therapy or memory making? It is scary for families to think, oh, I have to have a palliative care consult now. What does this mean? What does that mean? And I think what we have to recognize is that if a child is seriously ill and there is a potential of dying in the coming weeks, months, or even longer, the palliative care team can be an added layer of support. And on that, I think sometimes we have to be quite upfront. Sometimes I say, I'm coming into this meeting as a palliative care expert because we're very worried about your child. And, you might have heard about what our team does. Can you tell me what you think our team does? And then can I share with you some of the things that we might be helpful with? So that it's an exchange of information with the family and the clinician and not sort of this one-way referral. Go see them, or don't go see them because they're not ready, but that there's an exchange of it.
Yeah, it always it always makes me think and sometimes giggle when people say the family's not ready, because I always think about if your child has an infection, in the bloodstream, or they have appendicitis, it's not really an option to meet the surgeon or the infectious disease doctor. It's just part of care. It's part of good care, good clinical care, and that's what your child needs. So if a child has a serious illness where trajectory is potentially uncertain, the palliative care team is part of good care, right? Mm-hmm. So it shouldn't be an option. And I think shifting the perception of that, I think, is what we try and do really hard these days. And it's, it's slow, but I think people are coming around to the idea that having a palliative care team involved in a child who has a serious illness is just good clinical care.
Absolutely. And I think, I'm pondering the fact that in some ways it's getting easier where we work and how we work, but at the same time, it's still as hard as it was 30 years ago. Mm-hmm. So part of it is for me that I have to ground myself in believing that our service can be helpful and acknowledging that to meet us for the first time is hard. So I have to hold both things. I have to hold that the family's anxious to meet us, that they're nervous, they're not sure how we can help them. They want to avoid us even maybe sometimes, but then trusting within my own self and within the team I work in that we will be helpful and we sort of win families over. Families will often say, we wish we never had to meet you, but we also could never have done this without you. And so I would encourage people that are new to pediatric palliative care or are starting to build their repertoire of words of how you introduce your service is to really trust. It is hard for us to go into rooms. It takes courage, but really believing in the work that you and your team does to really enhance quality of life, processing, symptom support, family support. Because if you do those things, we do know that bereavement outcomes are better, that families make memories, and that the experience of having a seriously ill child is made less difficult.
Yeah, it's so interesting because I'm thinking of a mom that I was recently just talking to whose child has, what we call like a chronic cancer now. There's treatment after treatment after treatment, but they've been living with uncertainty and cancer that just isn't doing what it's supposed to for many years. And she's always been very scared to meet us. And she said, well, I just don't get it. Is he palliative then? Is he palliative? And we explored what that meant. And I said, what does that mean to you? She said, well, that means that there's no hope for cure. And I said, well, that's really interesting. I said, can I share what it means to me? And, we talked about, a holistic approach to care and how adult palliative care is very different than pediatric care. And, I think a lot of people's perception of palliative care is what they see in the adult world. And we talked through, all the things that we do. But I think I was telling her that some teams, some pediatric palliative care teams all across Canada have really shifted their title to be the quality of life team, for example, or, they've taken out that word palliative. And I'm sort of torn about it. I am. I think there's part of me, like you say, that we need to own it. We need to own that we're scary. We need to own that we do represent potentially a family's worst case nightmare.
We're end of life care.
Yeah, like we do, we take care of kids who die. But at the same time, I understand the shift in language and people wanting to potentially, replace palliative with quality of life team or whatnot. So I don't know. I don't have a right answer, but I think it's interesting that you have to hold both, that we know we do so much more than end of life care. And we bring, we had a podcast recently talking about the joys of palliative care. Kids who are living, they're laughing, they're playing, we're enhancing their quality of life. But we also have kids who have been very stable on our program and have a sudden event. And it reminds us all that we are a palliative care team. And so I think for people who are starting to think about building programs, like we talked about, and like Camara said, language is important. I don't know the right answer, but what you name your team is something I was just thinking about.
Yeah. And I what I like about your story is that you sat with that mom to explore what she thought. What do you think we can do? Because I think in that conversation, you were able to say, well, she's not dying right now. You already know that the options for her cancer are limited, and the oncology team, you, will continue to look for options. But we're also living with this uncertainty, with this knowledge that this cancer can grow and she can get sicker. And to not shy away from the word, but to say what this means, what this care means for you right now is that we get to know your family, we provide support around symptoms, we get family support in, and we navigate with you the uncertainty in which you're living. So dialogue, I think, is the most important thing around words. And no matter what you change your team's name to, it'll always have a meaning, negative and positive. And so I would be hesitant to change words too much, but I would always say, explore. What do those words mean to you?
Yeah, I think, and culturally, I think there's shifts in language and what it means in different cultures. So I think it's really important to explore what each culture views as palliative care. But at the same time, the other thing I was just thinking about as you were talking is we do seem like the end of life care team when we're introduced in that moment. But if you could introduce us sooner, when your child's well, when we can explore some rec activities, when we can get to know your child, we can help with their pain and get them out to school again. I think that really changes the dynamic between our team, other teams, and the family. So I think that's my plug for early involvement of palliative care. Because you can introduce us in a different way, right? We're not going in to talk about a compassionate extubation. We're meeting your child because they have a serious illness. So let's get to know you.
Yeah. For me, that the language that's changed over the last 3 or 4 years, instead of sort of life-limiting or progressive condition, which we've used for a lot of our time around, if your child has a life-limiting or life-threatening condition, you can come to Connect Place. But I think what really resonates with me more, and probably families, is your child who has a serious illness has all these teams, has all these specialists, and has this other team called Connect Place, because your child has a serious illness. And families aren't going to argue with that. They know their child who has to come for chemotherapy or is on BiPAP, or they know it's serious. You don't have to convince them about that. And so when you can come alongside with other professionals, other clinicians, to say, we too take care of children with serious illness, and we add in to the care. And if we meet them early on, it becomes such a good partnership with the family and with the other clinicians. Yeah.
Partnership. I like that word. I think that's what a palliative care team really hopes to do. Like when I work with other families and clinicians and teams, I really hope that it's a partnership rather than one versus the other, or one team steps away and the other gets involved. I think the collaborative care and the concurrent care is really what families get benefit from the most, I think. So
and to name that, I think in adult care, often what happens is there's a sense that there's nothing more we can do as a cardiology team or as a a cancer team or whatever, and so now you're going to palliative care. Now I think that's shifted to an adult care, but I think people sort of traditionally think that way, that it's this care stops and another begins. And so I think your point in really explaining to families, we are collaborative with your specialists. We're not replacing, we're not pushing them out, we're not your only team now. I think that's huge.
And there's no hidden message. I think families are often really scared if someone introduces us in a nervous way. I think families have said to me, I really felt like they weren't telling me something when they brought you in, right? And so I often just name that, like, this person isn't hiding anything from you.
Yeah.
You saw the scans, we're going to keep trying with this chemo, but they felt that we could be extra supportive. So sometimes I just name it, that nobody's hiding anything, because it really, I think lots of families feel that.
Yeah.
It's scary.
What aren't you telling me?
Yeah.
Totally. Well, this is really good, Natasha. I think, we could go on and on as we.
It's true.
But I'm hopeful that this is helpful to your listeners, and that we've given some ideas around how to introduce your team and your work to families and to your clinician colleagues.
Well, thank you so much for joining me, Camara, and sharing your, decades of wisdom. I won't tell how long, but thank you all for listening so much, and we'll see you at our next podcast. Thanks, guys.